So firstly, thank you very much for turning up to the first ever webinar which we have on gallbladder cancer. We want to explore multiple opportunities which we can have to reduce the incidences of gallbladder cancer in India. A quick introduction about Jarurat Care Foundation. Jarurat Care Foundation is a patient advocacy group specifically focusing on gallbladder and biliary tract cancer, which started in March 2024, stemming from a personal loss. We focus around creating a community for cancer warriors, caregivers, and doctors who are battling with gallbladder and biliary tract cancer. We focus on three different verticals, which is caregiver mentorship. First one, where we try to provide holistic cancer support to the families who are battling cancer. As we all know, it's a family battle altogether. Not just one person is suffering. We help the patient from the start of their journey till the end in every possible logistic way. We call ourselves cancer concierge in that terms. Secondly, it's about the preventative awareness. We all know that the incidences of gallbladder cancer are very high in India, and we want to bring in more awareness by working with the oncologist community, spreading awareness on different segments where people can work, what all things they should look after in order to reduce the incidences of this cancer, and also organizing such webinar sessions with the doctors to create more research platforms where people can come and share their thoughts. Lastly, we are also a research and advocacy group where we want to work with the doctors and researchers to bring in more novel technologies which can help in bringing down the incidences and enforce early detection of gallbladder cancer. So this is about Jarurat Care Foundation. I would also like to make a mention about Trucan Sentinel, which is a co-brand organization in this webinar. They are a research and development organization which is actively working towards identifying DNA mutations for different primary or metastatic recurrences of solid tumors. They are also working on several patented technologies that can help in predicting the response of chemotherapy and targeted therapies. They have been able to work with a lot of institutions in India already. They look forward to network with more and more oncologists so that they can bring their tests to the market. You can visit their website, which I will share after the call for more information. That's all about us. I would give it to Dr. Javle and Dr. Jill to kickstart the presentation.
Thank you very much, Priyanka. I'm Milind Javle from MD Anderson. It is my great pleasure and honor to introduce Dr. Jill Koshiol, who is a senior statman investigator in the infection and immunoepidemiology branch of the NCI, the National Cancer Institute. Jill is a passionate investigator. She has been interested in biology. Looking at her bio, it seems like it was in school and in college when she was a sophomore, which is like the second year in school, where she met a passionate teacher in biology and she got interested in the field. Her father is a pediatrician, and he said, well, why don't you do medicine? And she said, I don't really want to do medicine. And he said, well, how about epidemiology? She decided to do that because epidemiologists are sort of investigators. They're detectives, look for the cause of the disease, cause for infection. And that appealed to her young mind, and so we are so fortunate that that's what she did. Her focus has been on biliary tract cancer because there is a close link between infections, between toxins and exposures. And she has been investigating the epidemiology of biliary tract cancer in Chile as well as in India. She has identified many new opportunities for cancer prevention and early detection that will have public health impact. She has worked for many years with Indian investigator, and I regard her as a friend of the Indians and those passionate in this disease. So thank you very much, Jill, for being here. She's going to talk about gallbladder cancer in Chile and opportunities for cancer prevention.
Thank you so much, Milind and Priyanka. I'm really honored to have this opportunity to be here with you today. I want to talk a lot about the work that we've been doing in Chile to try to identify novel targets for cancer prevention and early detection. And then I'm hopeful that we can have a really great discussion about how this kind of work might be applicable in India as well, and how we can work together to really move the field forward. Because the reality is that very little work has been done on gallbladder cancer. So we have a lot to do together. So to put things in context, and just to make sure we're all on the same page, gallbladder cancer is one type of biliary tract cancer, and the gallbladder stores and concentrates bile produced by the liver to aid in the digestion of fatty foods in the small intestine. And the incidence of gallbladder cancer varies quite dramatically across different parts of the world. So this map shows you the age standardized incidence rates for gallbladder cancer in men and women globally. And as you can see by the different colors, there are really some places that constitute hotspots for this cancer. And this map is based on data from the GlobalCon 2022 database, which actually takes observed cancer rates from individual cancer registries in different parts of different countries to create an overall estimate, not observed rates, but an estimate for the whole country. Now, looking more carefully at the 20 countries with the highest gallbladder cancer incidence rates from GlobalCon 2022, you can see that Bolivia, Bangladesh, and Chile have the highest rates when we use these rates that are estimated across the whole country. India is still among the top 20, but near the bottom of the list. And I want to point this out because the picture looks a little bit different when you actually look at the observed rates from individual cancer registries. So here in this figure, you can see the top 3 highest rates and the bottom lowest rates for gallbladder cancer incidence rates among women by continent. So here the green circles indicate rates from Africa, the orange from Latin America and the Caribbean, the red North America, lilac Asia, purple Europe, and yellow Oceania. And what you can see here is that in fact, Valdivia, Chile has the highest reported incidence rates of gallbladder cancer in the world, but it's followed very, very closely by Kampung urban district in India. Now, because Chile has such high rates of gallbladder cancer, the Chilean government has established a program called AUGE, which started in July of 2005. And the goal of this program is to prioritize certain individuals for cholecystectomy or surgical removal of the gallbladder in order to try to reduce gallbladder cancer mortality and incidence. Now, the prioritization plan is just a little bit complicated, but I'll try to walk you through it. First, men and women aged 35 to 49 are prioritized for cholecystectomy. If they come in and they have symptoms, they undergo ultrasound. And if they're confirmed to have gallstones, they are to receive cholecystectomy and diagnosis by law within 6 months if they want to have surgery. Now, given that the average age for gallbladder cancer diagnosis living in the high-risk areas of Chile is right around 65 years of age, that means that this group of people really has a lower intermediate risk of gallbladder cancer. The next group includes asymptomatic women at age 40. So when women are age 40 and they come in for their regular adult preventive exam, they're to be screened for gallbladder cancer risk factors, which I've listed out here. Now, if one of those risk factors is present, then they are referred to ultrasound. And there's another waiting list for ultrasound, so it can take some time for the woman to have that ultrasound. If she has the ultrasound and gallstones of 3 centimeters or greater, or gallstone volume of 10 milliliters or more, or polyps of 1 centimeter or more are identified, then these women are also put on the waiting list for cholecystectomy, but they have secondary priority to that first group of men and women aged 35 to 49. Now, finally, men and women of all ages except 35 to 49, which usually means people age 50 and greater, are referred to ultrasound if they come in with a history of biliary colic or gallstones. And then they're first to be screened for risk factors for gallbladder cancer. And if they have them, they're referred to ultrasound. Then if gallstones are identified in this group, patients are added to the cholecystectomy waiting list. And there they have the very lowest priority for surgery. But at the same time, they really carry a higher intermediate risk for gallbladder cancer because these are older age individuals and gallbladder cancer risk increases with age. To try to understand if the AUGE program has had any impact on gallbladder cancer mortality, we analyzed the magnitude and trends of gallbladder cancer mortality in Chile as a kind of an indirect way to get at this question. So here you can see data from the Chilean Ministry of Health mortality database. And this first top line, the gray line, is the age-adjusted mortality rate for women, followed in the dark blue by the crude weight rate for women. And then lower, you can see that men overall have lower mortality rates with an age-adjusted rate, followed again by the crude rate. And what I want you to notice here is that AOHE began right between 2005, 2006. But in fact, we see a decline in the mortality prior to the initiation of the AOHE program, especially among women. Now, looking more carefully at the trends in gallbladder cancer mortality by age and sex, we used something called join point analysis to see if we saw inflections in that mortality trend over time, or changes in the slope of the line. And what we found is that the rates actually declined more rapidly in women age 35 to 49, right around the years 2007 for women age 35 to 49 in the left-hand panel, and around 2010 for women age 50 to 59. And that is consistent with the hypothesis that the introduction of AOHE might have contributed to a greater decrease in mortality in women who had some coverage by the AOHE program. In men aged 35 to 59, we found that the rates dropped just a little bit later in 2011 to 2013, which might reflect a slower uptake in men. The rates also declined in men and women who are age 60 and above. So here in the panel on the left, you can see women age 60 plus, and on the right, men age 60 plus. And in both of these groups, this inflection point, this trend towards a stronger downward decline, happened right around 2007. And these drops really can't have been due to the AOHE program, because very few people in this age range had any coverage by the AOHE program. But it is possible that it might reflect the impact of public health interventions to control typhoid fever in the mid-1980s and mid-1990s, although we don't know why that long ago intervention showed up in 2007. Looking more closely at the observed to expected mortality rates, we found that younger female cohorts with more years of AOHE coverage tended to have larger drops in gallbladder cancer mortality than expected, based on the decrease in mortality that we saw from prior cohorts. So here I'm showing you an example with the observed mortality rates for women aged 40 to 44 compared to what we would have expected based on the mortality rate experienced by the two previous 5-year age cohorts. So each of these rate ratios compares the observed to expected mortality for different time periods and birth cohorts. You can see that I've given you the time period in the birth cohort at the bottom of the figure. And each of these time periods and birth cohorts also has different amounts of coverage by the AOHE program, from none up to 5 to 9 years, which I've listed at the bottom. So when the observed to expected ratio is below this, well, the blue line's kind of in the wrong place. The blue line should be at 1. But when it's below 1, then the observed to expected mortality is lower than what we would have expected based on what we saw in previous cohorts. And while the pattern isn't entirely consistent here, you can see that women who had AOHE coverage tended to have lower observed mortality than what we would expect based on previous age cohorts. So has the Chilean AOHE program reduced gallbladder cancer mortality? Well, probably. Our results tend to suggest that it has, because we do see more rapid declines in gallbladder cancer after the initiation of the AOHE program. And another publication by Gonzalez et al. Used a different statistical approach and also concluded that AOHE probably reduces gallbladder cancer mortality, suggesting that AOHE is having an impact. But it might not be the most efficient approach, since older age patients with gallstones are left waiting for cholecystectomy for extended periods of time, so often for years. And cholecystectomy has been associated with increased risk of metabolic disorders, steatotic liver disease, and other gastrointestinal cancers. And since we don't fully understand the long-term effects of cholecystectomy, targeting young people for cholecystectomy might not be the best option. So what can we do? Well, one approach is to try to understand what drives the progression to gallbladder cancer among people who have gallstones. But this approach is a little bit tricky, and I want to kind of walk through why that is. First, gallstones are the single most important risk factor that we know of. Gallstones lead to chronic cholecystitis or inflammation in the gallbladder, and then additional factors are needed to contribute further molecular changes that lead to the development of intestinal metaplasia, dysplasia, and then finally cancer. So based on this model for gallstone-related gallbladder carcinogenesis, there are really two important pieces to think about. First, what are the risk factors for developing gallstones? And then, once you have gallstones, what are the risk factors for developing cancer? Now, the clinical mantra for the major factors associated with gallstones is female, fat, fertile, and 40, the 4 Fs. And these same risk factors are associated with an increased risk of cancer. So it's hard to sort out whether these factors are associated with cancer purely or only because they increase the risk of gallstones, or whether they also have some independent or additional effect on the risk of cancer once you have gallstones. And it's been really difficult to evaluate this second piece of the puzzle because the vast majority of cancer cases have gallstones, while only about 10 to 20% of people in the general population have gallstones. So a key question is what drives the progression to gallbladder cancer among people who already have gallstones? Now, Chile is a good place to address this question because it has a high prevalence of gallstones. And as you've seen, it has among the highest rates of gallbladder cancer in the world. The rates are particularly high in the southern central region of Chile, where there's also a large proportion of people with Mapuche Amerindian ancestry, which is the major ethnic group in the region. There are also many exposures of interest that have been understudied, such as genetic admixture, Salmonella, Enteric cerevisiae, typhi, heavy metals, and aflatoxin exposure. And all of this means that there's an important potential to have an impact on public health because really there's a vital need to find better ways to identify individuals who are at high risk of having or developing gallbladder cancer so that they can be prioritized for cholecystectomy. For these reasons, I designed the Chile Biliary Longitudinal Study, or Chile BILS, which first identified 29,000 women aged 50 to 74, and then screened about 19,000 women for gallstones using ultrasound, getting us down to a gallstone cohort of about 4,700 women. We're still continuing some limited follow-up in this cohort of women, but so far we've identified 73 gallbladder cancer cases and 49 high-grade dysplasia cases. We've had really outstanding follow-up with 94% compliance at our year 2 visit and 93% compliance at the year 4 visit, and over 2,800 cholecystectomies completed so far. To enrich the number of cases, in 2022, I added a case control component that's going to continue through July of this coming year. And so far, we've recruited 259 gallbladder cancer cases and 303 matched controls. The primary aim of Chile BILS is to investigate the epidemiologic and molecular risk factors for gallbladder dysplasia and cancer, with primary exposures of interest including things like aflatoxin, inflammation markers, obesity, diabetes, and metabolic syndrome. And I'm going to talk a little bit about the first two of these things in the presentation today. Another aim is to characterize the stages of disease in gallbladder cancer. In other words, what factors are associated with intestinal metaplasia, low-grade dysplasia, and finally high-grade dysplasia and invasive cancer. We have really extensive biologic specimen collection in Chile BILS that's going to vastly facilitate these efforts by enabling in-depth evaluation of the molecular epidemiology of disease. To give you a sense of the baseline characteristics of the cohort, 55% of the cohort were age 50 to 59 at baseline. 53% had 8 years or less of education. 25% reported having Amerindian Mapuche ancestry. About 60% were obese. 25% had diabetes and 6% had cardiovascular disease. Importantly, only about a third of the cohort reported having had experienced biliary colic at baseline. And that's valuable because it means that 2/3 of the cohort were really asymptomatic at baseline. We wanted to be sure in this study to capture the whole spectrum of gallstone disease, not just symptomatic gallstones, but asymptomatic gallstones, since in fact, the majority of people with gallstones are asymptomatic and don't know that they have stones. So this finding shows that we were really able to achieve that important goal. To give you a summary of the baseline of the biologic samples we're collecting, at baseline, we collected lavender top tubes, which gives us plasma, red top tubes, which gives us serum, and also PAX gene tubes, which allow us to evaluate RNA expression. And then at the 2 and 4 year visits, we again collected plasma and serum. When people went to surgery, we weren't always successful, but we did try our best to get pre-surgical plasma and serum, and then also to collect FFPE tissue on about 90% of people who went to surgery, and then a smaller portion we were able to get fresh frozen tissue, RNA-later tissue, bile, and gallstones. We have extensive epidemiologic data, biospecimens, and digital images in Chile bills. And just to give a few examples, we have baseline questionnaire data on 99% of the cohort, baseline blood on 96%, a growing repository of digital images, including over 300,000 ultrasounds, about 6,000 videos, and 35,000 digital H&E slide images. Now, in addition to the surgical specimens that I've listed here, as I mentioned, we have FFPE on about 90% of the cohort. As an example of how we're already beginning to use Chile bills, I want to give you a quick summary of an analysis that Ilona Argirian, who was a former postdoc here at NCI and now is a professor at Georgetown University, has been leading. And the goal of this study is to really understand how much of the gallbladder do we need to look at in order to identify gallbladder cancer, and importantly, dysplasia, which is the step right before gallbladder cancer. So to do that, we compared the diagnosis that we would get if we took just one diagnostic strip, one longitudinal strip of the gallbladder, versus the diagnosis that we would get if we looked at the whole gallbladder. We found that when we used the diagnosis of low-grade dysplasia or greater versus diagnoses less than low-grade dysplasia, the sensitivity was 30%, meaning that we only found low-grade dysplasia or worse 30% of the time that it was there. So that's not super great. The kappa measures the agreement between the diagnosis based on the diagnostic slide versus review of the whole gallbladder, and that was 0.44, which is also fairly poor agreement. When we used high-grade dysplasia or greater, the sensitivity improved somewhat, but it still wasn't very good. And even when we used invasive cancer as the cutoff, we found that the sensitivity was 60%, which means we would still miss 40% of the cases if we only looked at those single longitudinal strip diagnostic blocks. That's important because it demonstrates that if you don't review the entire gallbladder, you'll miss the majority of dysplastic lesions, and you might also miss a substantial proportion of invasive gallbladder cancers. But that said, reviewing the whole gallbladder for everyone who goes to cholecystectomy is quite time and resource intensive. So one of the ways that we're trying to address this challenge is by developing artificial intelligence algorithms for application in digital H&E slide images, so that we can at least help triage what's important and what's not, and direct pathologists to regions that might need more careful review. We're currently working on developing 2 different algorithms, one to calculate stromal cellular density, which will allow us to better define the immune and inflammatory processes that are going on in the tissue and to understand the biologic mechanisms involved. And that algorithm requires accurately distinguishing between the stroma and the epithelium so that you can count the immune cells that are in the tumor tissue versus those that are surrounding the tumor tissue or other lesions of interest. And the other one is to differentiate specifically between gallbladder cancer and non-cancer. The stromal cellular density algorithm will allow us to evaluate whether the tissue immune profile differs by disease status from chronic cholecystitis all the way through invasive cancer, as well as looking to see how it's associated with other factors like nonsteroidal anti-inflammatory drug use or NSAID use, ethnicity, and other factors. And that's important because it means that if we see, for example, that NSAID use is associated with a reduced risk of developing gallbladder dysplasia, high-grade dysplasia, and gallbladder cancer, we can look in the tissue and see if NSAID use is also associated with a change in that stromal cellular density or the immune profile that we see in tissues. This approach gives us broad brushstroke data across a large number of individuals, but we're also working on going more deeply into the immune profile in a smaller number of individuals using GeoMX to test for proteins that indicate the presence of immune cells and immune checkpoint markers. Now, all of these things are still works in progress very much, but I would like to share some preliminary results from the stromal cellular density algorithm. And just to make sure that we're all on the same page, the metrics used to determine how well the AI algorithm is actually performing includes precision, also known as positive predictive value, which answers the question, out of all of the positive predictions that we made, everything we said was true, how many of them actually were true? And then recall, or sensitivity, which answers the question, out of all of the annotations that should be predicted as true, the ones that actually were true, how many of them did we correctly predict as true? And finally, the F1 score, which provides a single metric that combines both precision and recall, balancing the trade-off between the two. And here you can see our very, very preliminary results based on a training set of 18 images from Chile Bills and a validation set, 4 images, as well as a test set of 5 images. So all of this work right now is in Chile Bills. We're working on expanding this to digital images from other populations, including Georgetown in the US and Taiwan. But for now, what I have to share is what we've seen in Chile Bills. And in Chile Bills itself, we see really positive findings, really strong results. So in this first little table, you can see the precision, recall, and F score for the stromal component of tissue or non-epithelial tissue. And you see that all of these things are quite high, from 98% to 100%, which is very striking, and also makes us want to make sure that this algorithm works in other external populations. And then epithelial tissue, again, we have very strong results, a little bit lower sensitivity here, or recall, which we're working on tweaking a bit. And then when you look at the overall combination of the stromal component and the epithelial component, you can see that the algorithm is really doing a pretty good job of being able to distinguish between the two. And that's what we need in order to accurately be able to count the immune cells and give us that stromal cellular density in the stromal component versus the epithelial component. In addition to these ongoing analyses, I'd like to give 3 examples of future areas of research that I think are really important, that will be vital, and the Chile Bills will provide us some additional information, but I think are also really important to consider how we can address them in India as well, because these are the kinds of things that I think might help take us the next step in gallbladder cancer research. And that includes aflatoxin, circulating inflammation markers, and liquid biopsy. Beginning with aflatoxin. Aflatoxin's of interest because it's been known for many years that it causes liver cancer. And these aflatoxins are toxins that are produced by fungal infections, certain kinds of fungal infections that grow on corn, peanuts, spices, other ground nuts. And this kind of food contamination can lead to exposure of aflatoxin, which is known to be a liver toxin, but we think might also relate to gallbladder cancer risk, because in fact, there's experimental animal and occupational data to support an association between aflatoxin and gallbladder cancer, giving its biologic plausibility for this association. Another previous study tested certain food products in Chile and found that things like red chili peppers, which are commonly consumed, especially in the southern central part of Chile, were often contaminated with aflatoxin. And at the same time, there's a low prevalence of other cofactors for liver cancer, like hepatitis B virus, which might help explain why liver cancer rates are low in Chile, but gallbladder cancer rates are high. But despite this evidence, nobody had actually looked directly for an association between aflatoxin and gallbladder cancer until we looked at it. So we started off by looking in a pilot study that I conducted in Chile as a preliminary step to getting Chile bills started. And this is work that I did together with my former postdoctoral fellow, Leticio Nogueira, who is now at the American Cancer Society, and John Grootman at Johns Hopkins University, who did the testing. So here we took these samples, and in this figure, you can see that each bar represents the level of aflatoxin lysine adducts in population-based controls, gallstone controls, and gallbladder cancer cases. The red line indicates the lower limit of detection. So any of the bars that are below the red line did not have detectable levels. And what you can see is that gallbladder cancer cases were more likely to have detection of aflatoxin and more likely to have higher levels than either of the control groups, producing an odds ratio of greater than 13 for cancer cases compared to the population-based controls, and greater than 9 for cancer cases compared to gallstone controls. Just to remind you, with these kinds of ratios, anything that's above 1 suggests that there's increased risk, and anything that's below 1 suggests that there's decreased risk. And these odds ratios are particularly high. Usually for studies of cancer, we're really pretty happy if we see odds ratios of 2 or 3. So here, seeing odds ratios of 13 and 9 is quite striking. But this is just one study. And as you can see, the numbers get pretty small in this study. So we wanted to see if we could replicate this finding somewhere else, and therefore turned to the Shanghai biliary tract cancer case control study, where we found that aflatoxin was detectable in 32% of gallbladder cancer cases and 15% of gallstone controls, leading to an odds ratio of 2.7. A little more what we might expect to see, but still a very strong association for gallbladder cancer and aflatoxin. Then when we restricted the association to people who had detectable levels and looked at people who had the highest quartile compared to the lowest quartile of aflatoxin level, we found that the odds ratio for gallbladder cancer compared to gallstones began to approach 8, which again is very strong finding. I then sought to replicate this finding prospectively using baseline samples from the Shanghai cohort study in collaboration with John Min Yuan from the University of Pittsburgh. And here the odds ratio for the detection of aflatoxin lysine adducts was 2. So the risk of gallbladder cancer over the whole course of the study was about twice as high in individuals with detectable aflatoxin at baseline. Although I do want to point out the confidence intervals here. These are pretty wide confidence intervals, which suggests that this association is imprecise. We need more information to get a more precise estimate of this association. The median time to diagnosis was more than 18 years, and that's a long time. So we also restricted the analysis to people who were diagnosed from the time of blood draw to less than the median time of diagnosis, and found that in this group, the odds ratio was 2.2, which is pretty similar to that overall odds ratio of 2, and suggests that this really reflects a long-term persistent effect of exposure to aflatoxin on the risk of developing gallbladder cancer. And finally, we found that individuals who reported both gallstones and had detectable aflatoxin lysine levels had 9 times the risk of developing gallbladder cancer compared to those without gallstones or aflatoxin detection. And then I'm so happy that Dr. Usha Dutta is here with us today, because her group just recently published these findings using case-controlled data from the high-risk area of India, and showed, again, a strong association between aflatoxin and gallbladder cancer with an odds ratio of detection of nearly 6, here 5.7. And this, I think, is really important, because now it's not just us who are seeing this, right? You guys are seeing this too in a very area with a very high risk of gallbladder cancer. We also conducted a molecular profiling study of gallbladder cancer and found that about 40% of the cases we tested had the aflatoxin-associated single base substitution mutational signature. And when these mutations were present, they tended to be present in the majority, meaning at least 50%, usually more, of the cancer cells. And that suggests that aflatoxin had an effect early in the development of gallbladder cancer. Taken together, these findings suggest that aflatoxin might increase the risk of developing gallbladder cancer. But part of the difficulty with studying aflatoxin is that the exposure has been reduced in many places, including in China, where most of the cases in this study came from. So Chile Bills offers an important opportunity to prospectively assess the association in a high-risk population where we didn't know that aflatoxin was a problem until recently. And I think Northeastern India also provides another great example of a place where it's really important to look at this and to try to look at it prospectively, if at all possible. And even more importantly, I just want to demonstrate how this kind of work can have an impact. I presented the results of the case control studies on aflatoxin in the Chile and Shanghai studies to the Chilean Ministry of Health in October of 2016. The Chilean Ministry of Health then went and tested Merken spice blends, which include that red chili pepper previously shown to be contaminated with aflatoxin for mycotoxins. And that eventually led them to pull one brand off of the shelves and to issue a public food safety alert. And it's still having an impact today. Chile now has an ongoing program of surveillance for mycotoxins in Merken. And in fact, I was in Chile just this last August when one of my travel companions bought this specific brand of Merken. And then one of our colleagues subsequently sent us a notification that 2 lots of this particular Merken brand had just been recalled due to high levels of mycotoxin contamination. This action demonstrates the seriousness with which the Chilean government takes these findings and the potential for this kind of work to really have an impact on public health policy that could lead to an improvement in people's lives. If we do establish that aflatoxin is a risk factor for gallbladder cancer, then we can potentially reduce the burden of gallbladder cancer by reducing exposure to aflatoxin. Another area of research I think might be particularly impactful is evaluating the utility of circulating inflammation markers for the detection of gallbladder cancer. And in this figure, I'm showing you the odds ratios and the 95% confidence intervals for 49 different inflammation-related proteins and their association with gallbladder cancer compared to gallstones. We found that half of these proteins were associated with gallbladder cancer, and of those, 7 proteins were associated with early stage 1 and stage 2 gallbladder cancer. Then we put these 7 proteins all in one model together and did backwards modeling and found that 4 of those proteins remained independently associated with gallbladder cancer. So we used those 4 proteins to create an inflammation score. And then when we looked at the highest quartile versus the lowest quartile of the score, we found that the odds ratio for gallbladder cancer was 42. So individuals who had the highest level of the score had 42 times the odds of developing gallbladder cancer, of having gallbladder cancer. These findings are important because treatment can make a big difference for localized tumors. When you look across all stages, the 5-year survival is quite low, 15 to 20%. But the 5-year survival is much higher for early stage cancers, 41% for localized tumors and nearly 90% for tumors that are confined to the muscularis. And what would be even better is if we could identify people when they still have dysplasia, which is the step right before cancer. But in this study from Shanghai, we didn't have information on dysplasia, and that's something that we can address in Chile Bills. Just to give you a sense of how inflammation markers might have an impact, suppose that we have 1,000 patients with gallstones who are on the waiting list for cholecystectomy in an area with high risk of gallbladder cancer. Based on the pilot study that we conducted in Temuco, an area with very high risk gallbladder cancer in Chile, we estimate that perhaps 10% of the population might have gallbladder dysplasia or cancer in regions with high risk for gallbladder cancer. And then using the inflammation score that I just described in the previous slide, we can plot the sensitivity of the marker on the y-axis and the specificity on the x-axis to produce a receiver operator curve with a corresponding area under the curve of 0.89. And then using this curve, we can identify a cutoff that would give us 90% sensitivity for gallbladder dysplasia and cancer and a corresponding specificity of 67%. So coming back to our 1,000 patients on the waiting list, we would have 391 individuals who would be positive for the inflammation score. And those 391 individuals would include 90% of the individuals with dysplasia and cancer. So by shifting less than 40% of the patients on the waiting list, we could detect most of those where rapid treatment could potentially make a difference. Now, it is important to keep in mind that the marker data that we have so far are only based on people who have cancer versus those who don't. And therefore, this really presents a best case scenario. Chile bills will allow us to see whether some combination of markers might be effective in a setting that includes individuals with both dysplasia and cancer. And finally, I'd like to talk about some work that cancer prevention fellow Mike Daniels and I have been doing to explore the utility of liquid biopsy in identifying patients with gallbladder cancer. Mike and I carried out a small pilot project that included plasma samples from the Shanghai biliary tract cancer case control study and the Chile pilot study using low coverage whole genome sequencing for fragmentomics analysis. And importantly, these samples were respectively collected from 1997 to 2001 in Shanghai and in 2013 for Chile. So they differ in storage time. And that's important because when we started this pilot work, we weren't sure if we could use really old samples to detect cell-free DNA and to do fragmentomics analysis. Now, this is still very much a work in progress. Mike is daily working on these analyses, but I'm excited about the results and I wanted to share the preliminary findings. And so far, those findings are very promising. First, we looked to see if there were study-specific differences in cell-free DNA yield. And here you can see in the left-hand panel the overall amount of cell-free DNA, and the right-hand panel shows you the percentage of fragments that are in the range of 90 to 150 base pairs. And that's the range of fragment size that people have found to be enriched in cancer in other studies. And what you see is that both for the total cell-free DNA and for the percentage of fragments, shorter fragments, that the pattern really looks very much the same, whether we looked at Chile or in Shanghai. And tentatively, that suggests to us that storage time might not be a major concern for this kind of analysis. We also saw that individuals with gallbladder cancer had the highest amount of cell-free DNA per milliliter and the highest proportion of short fragments. And that, again, was consistent with our expectations based on what other studies and other cancers have seen. Looking more closely at the fragment size distribution, individuals with gallbladder cancer had much greater enrichment of the shorter cfDNA fragments compared to individuals with gallstones and controls. And so just to point out, what we're looking at here is the kind of rough area on this curve, on the left-hand side of this curve. That's the area that others have found to be enriched in cancer cases. And then in the corner, you can see kind of a blow up of this area. And what you see is that the pink line, which is the gallbladder cancer cases, is above the black line and the blue line, showing, again, enrichment of this fragment size in gallbladder cancer cases. To expand on this finding, we generated binwise short to long fragment ratios, which compares the fragment ratios that are in that about 100 to 150 base pair range to longer fragments in 5 megabase bins across the genome. And what this shows you, if you look at the bottom part of this graph with the gallbladder cancers in pink, is that there's quite a bit more variation in the gallbladder cancer cases than in either the gallstone controls or the healthy controls. And collectively, these findings are consistent with the literature and provide us with confidence that these plasma samples can still be used for cfDNA-related projects. Now here you can see some initial preliminary results for copy number alterations. And again, this is ongoing. We will have more data on copy number alterations. But just to begin with, you can see that we have data from one control showing copy number alterations in cell-free DNA, and then from 5 gallbladder cancer cases. And for this last gallbladder cancer case, we actually had paired cell-free DNA and paired tumor data. We do have some more of these paired samples. It's just that the processing is still happening. And what we can see with this initial pass is that in the control, we really don't see any copy number alterations. You can see everything here is blue. There's no green indicating deletions or dark red indicating gains or lighter red indicating amplifications. That's great. We don't want to see copy number alterations in regular healthy people. But you can see that the cancer cases, when we looked at copy number alterations in the cell-free DNA, did have evidence of deletions and amplifications and gains. And then when we looked at the person who had paired copy number alteration data from the cell-free DNA that we got from the blood to the copy number alterations in the actual tumor tissue, you can see that this pattern of colors looks pretty similar in the tumor and the cell-free DNA, suggesting that what we're seeing in the cell-free DNA from the blood really is reflecting what's happening in the tissue itself. And that is very reassuring. So based on these promising initial findings, we developed a larger study that we're conducting right now in the Shanghai biliary tract cancer case control study with about 100 individuals with gallbladder cancer, a similar number of individuals with gallstones, and then a representative set of population-based controls. We've pulled people who have at least 2 mils of plasma, and then again are using low coverage whole genome sequencing. And ultimately, we want to apply these methods to Chile bills, both so we can validate what we see in Shanghai, but also to see if baseline fragmentomic features, so fragmentomic features pulled from cell-free DNA that we get from those baseline samples prior to the development of dysplasia or cancer, can predict the future risk of developing cancer, as well as precursor lesions like dysplasia. And I do think that that's really important. Our hope is that some of this work might help inform who's at the highest risk for having or developing gallbladder cancer, and thus could potentially benefit the most from earlier cholecystectomy. And finally, I'd like to close by emphasizing some of the key aspects of Chile bills that make it an important resource for the future of gallbladder cancer research. To my knowledge, this is the first epidemiologic gallstone cohort in a high-risk region, although I know that Dr. Dutta is also working on a gallstone cohort in the high-risk area of India, which I think is so important and is going to be invaluable for making comparisons across these different high-risk regions in the world. There's also a high prevalence of understudied exposures. We have extensive biospecimen collection that will allow us to investigate changes across the stages of disease and to do molecular profiling that will help us better understand the biologic mechanisms that underlie any associations that we observe between risk factors and high-grade dysplasia and gallbladder cancer. We have extensive imaging data over time, including ultrasound images over time and digital H&E slide images. And all of this together means that there's a great deal of potential to translate our findings into a positive impact on public health and public health policy. For example, by finding biologically meaningful ways to prioritize people for cholecystectomy. Lastly, I want to acknowledge the many people who have been involved in the studies that I shared today, which involve multidisciplinary collaborations with a huge team of expert collaborators and colleagues, really from all over the world. International collaborations are critical to do this kind of work, and Chile Bills demonstrates that beautifully. And my hope is that we can expand these collaborations to build a global network of investigators who together can make great inroads into gallbladder cancer early detection and prevention. And finally, I just want to highlight the diverse group of fellows and former fellows who have gone with me to Chile or who have come from Chile. Many of these individuals are leading the work in Chile Bills today, and these are the ones who are making things happen. So I cannot thank them enough. And I thank you as well for your time and attention.
Thank you so much, Jill. This was a fabulous tour de force. We have really very little time, but I'm going to request the people here if you can ask some brief questions and brief answers so we can get through them. I know I have several, but I'll prioritize anybody who is asked. I think someone raised a hand already. Yeah.
Yeah, just a couple of things. I was trying to see if we should actually be using an image program to scan the gallbladder once it is coming out at cholecystectomy, because once we take it to the pathologist, then they go in through the H&E sections, and that is a very laborious task for them. As an endoscopist, I realize there's so much of new technology coming in looking at the mucosa using image enhancement, narrowband imaging, because we are using that to pick up intestinal metaplasia in endoscopy in the stomach. And actually, gallbladder cancer works the same way as gastric cancer. So I was just thinking that, we could use such kind of endoscopic technology on site in the operation theater and mark the areas which are diseased, and that gets to the pathologist, because otherwise screening such large tissue may be a problem. And a quick thing is that we are doing a pan-India study, which is a cohort study of asymptomatic gallstones and symptomatic gallstones and gallbladder cancer. Our target is 3,000 asymptomatic gallstones. We have started community screening. We're looking at aflatoxin, Salmonella typhi, H. pylori, and the various risk factors, and also collaborating with Jill on other aspects regarding this disease. My question to Jill is that the cell-free DNA in gallbladder cancer detection versus an AI tool to pick up gallbladder cancer on ultrasound, I think an AI tool for gallbladder cancer on ultrasound will be greater value for money and time. I wanted her input on that. And also to use AI technology on nuclear cytoplasmic ratio, which cytologists use to pick up early cancers and dysplasia in the tissue, may be a good way to go forward. Congratulations, Jill, for an excellent lecture. Thank you.
Jill, maybe I think it's like a multi-pronged question. What is it like? We're talking of imaging with gallbladder cancer, novel technologies incorporating in endoscopy as well as ultrasound.
Yeah. So Usha, I think those are all really great points, all definitely things to be considered. I think the idea of using imaging, so let me see if I understand you correctly. Are you saying that when the surgeon takes the gallbladder out of the person through cholecystectomy, that even there in the operating room, you can open it and take a macroscopic picture of the gallbladder and then use AI to try to understand how there might be regions that the pathologist should look at specifically? Is that kind of what you're thinking?
I think so. Yeah.
No, I think that's actually a really great idea. As far as I know, it has not been done yet. But I agree with you that the place to start is by getting the images so that you can do the analysis. And in fact, in Chile bills, we do have macroscopic images of the gallbladder. So this would be a great place where we could potentially look to see, can we develop an algorithm? And once we do that, how does it function in Chile versus in India? Do we see the same kinds of features or do we not? Because I agree with you, like processing the whole gallbladder is very intensive and not really possible to do for everybody who comes through cholecystectomy. So we do need ways to triage and to understand better what are the areas of high risk. But right now, without AI or any kind of tool to help us, these gallbladders are just going through and nobody's seeing what kinds of features might indicate increased risk.
So yes, I think we should, in our conversations, we have been talking about an AI-based tool, and that's sort of where we are headed imaging. If there's no other question, I have a quick question. Can you run through those numbers again, Jill? You screened, 20,000 people, you found 4,000 gallbladders, and you found how many cancers? So what was the actual ratio and all that in Chile?
well, I can speak to Chile bills, the study that we've conducted with about 4,700 women.
Yeah.
So I could say out of 4,700 women, we've had 122 gallbladder cancers and high-grade dysplasias. That's 2.5%. If you restrict it to the 2,800 women who went to cholecystectomy, that increases to 3.3%. If you also include low-grade dysplasia, which I haven't included so much yet because it can be a challenging diagnosis, but if you include low-grade as well, those percentages increase to 6% in the whole cohort and almost 9% in people who went to cholecystectomy. So it's about what we would have expected based on the pilot study we conducted.
So it's a pretty high number, no, Dr. Kapoor? 2 to 3% of all the gallbladder of the cholecystectomies had high-grade dysplasia or cancer.
Yeah, but probably there is a selection bias.
Yes.
The comment I wanted to make was that I urge all investigators who are looking into gallbladder cancer to please remember that a proportion of patients with gallbladder cancer do not have stones. This proportion is low in Chile, about 5 to 10%. It is about 20 to 30% in India, and about 40 to 50% in East Asia, Japan, Korea, and China. So I have been saying this, although I have no evidence to prove it, that these are two different diseases. Because when we say that the pathway is gallstones, chronic cholecystitis, metaplasia, and all, what about those patients who do not have gallstones? So we have to remember this. And when we are comparing cases with controls, patients with gallbladder cancer need to be subdivided into two groups: gallbladder cancer with stones and gallbladder cancer without stones. Gallbladder cancer with stones should be compared to gallstones and chronic cholecystitis. Gallbladder cancer without stones should be compared with healthy controls. No stone, no cancer.
Yeah, I mean, sorry, PSC patients in my practice with gallbladder cancer. Sorry, somebody commented?
Yeah, Dr. Zawli, this is Raman. I want to ask the question after you finish.
Yes, go ahead, please.
Yeah, responding to what Dr. Usha said, in cervical cancer in India, right? I believe there are some parallels. There is a decrease in gallbladder cancer in Chile, and perhaps it's not because of the AUGE program that was set, because the decrease seems to have predated the start of that program. In cervical cancer in India, we see a considerable decrease, and we don't know why. Right. So we have to look at the epidemiological reasons why these two cancers are decreasing spontaneously with us not understanding why. The second is, can we use a simple stain on resected gallbladders with let us say, there is a use of acetic acid to look at cervical dysplasia and cervical cancer in India. Is there something like that we can do for resected gallbladders to select places where you need to actually do the histopathology, rather than go and try to do histopathology where you may not find something and you may miss some dysplasia?
I think that's a very interesting idea, sir. Only thing is the acetic acid is working with squamous cell. So we do use it in esophageal cancer screening. But I think basically we should be considering some chromoendoscopy kind of some dye which picks up these abnormal areas, which can be then targeted for histopathology.
Yeah.
Very good idea, sir. So I just wanted to bring one small question. Here we have ignored one aspect, that with left heart, we keep looking at ejection fraction of the left heart as a marker of function. Gallbladder is also a physiological organ which contracts every time. So a diseased gallbladder does not contract. And we did find that poor gallbladder function was associated with increased metaplasia in the gallbladder. So apart from just looking at gallbladder as just a structure, to also look at incorporate the function as a marker of a diseased gallbladder.
Maybe one last question, Amol. We have run out of time. Yeah, Amol, do you have something to ask?
I feel the gallbladder is multifactorial, is not one disease. Now we have figured out that the BTC is not one disease. Gallbladder, cholangio, extrahepatic, intrahepatic, they are all different diseases genomically. For gallbladder, for one thing which I want to highlight here is that we have the Patna Cancer Registry, hospital-based cancer registry, in which the gallbladder is the #1 killer. So don't look at the India as perhaps the only Globocan as a truth, because it's a county of a multiple counties as a country as India. So the entire northern belt, I generally call it as a sub-Himalayan belt, which has been, and there are hotspots within the hotspots, which I have realized after coming to Lucknow. My question about for Dr. Jill is, what about the germline hereditary prevalence in her experience? Because there is a data of 950 patients from the Foundation 1, which has showed that the BRCA2 positivity is around 4.8%. So that is quite huge. Is such kind of experience she had about the BRCA-related diseases in gallbladder?
I think it's a really interesting question. So gallbladder cancer, there have been a few small studies that have suggested that there's some heritability, because they've just found that family history of gallbladder cancer is associated with increased risk of developing gallbladder cancer in the children, and also some analyses that have looked at migration of people from high-risk places to low-risk places, and find that even after people migrate, that there's still an increased risk. That said, we don't tend to see the patterns of family associations that you see with strongly penitent genes. So I think that this finding with BRCA is really interesting. It definitely deserves to be followed up on. But at this point, we just need to do more work to really understand well what the heritability is.
I mean, there's so much to talk here, and there's so much excitement. But unfortunately, we have run out of time, and I want to recognize this is late in India, and I want to get back, all of you back to your families. So Priyanka, thank you so much for organizing this and for your sponsorship. Jill, a wonderful job as always. I hope that you will continue to work with us. And for the whole group, I'm hoping, Priyanka, that you will continue in your effort to make this cancer history, and also organize these seminars on a regular basis. So if anybody has suggestions and ideas for who to invite, please forward them on to Priyanka, and we'll do what we can. So thank you very much. And that was a wonderful first seminar, and much appreciated, Jill, as always.
Thank you all. It was an honor to be here. And thank you, Priyanka, so much for your work. It's so important.
Thank you so much for your time, and everyone to come up here and share your thoughts. Very much appreciated. Thank you.